Welcome back. Dr. Lehmann is going to kick off our next session with when and how to switch.
Okay, so do you see my slides? Everything okay?
Yep, everything looks great. Thank you.
Okay, thank you. So I'm very happy to be here. So here in Germany, it's already night, and that's like here for you, middle in the afternoon, so a little tired. And so the topic will be when and how to switch. These are my oh, it doesn't work. Sorry. Okay, so the learning objective today will be how to switch in the setting of viral suppression, and also discuss how it's possible to switch IRT to long-acting cabotegravir and rilpivirine, and also what we have to consider and to discuss if you observe a virologic failure. And I will start with the first case. Can I switch patients with viral suppression in the setting of some mutation, the characteristic one, 184 and K65R? And I will start with a case, a woman, 42 years old. And she was diagnosed with an HIV infection in the winter 2019, was a late presenter with cerebral toxoplasmosis, very low CD4 T cell counts of 150 and 15%, quite high viral load. And then the treatment was started a few weeks later, based with darunavir, and now her lab values, the HIV RNA, dropped very quickly, and now is still below 20 copies, and CD4 T cell counts increased up to 400. The problem is that she has high levels of cholesterol and is also a smoker. And as we just discussed earlier, also, we are not only treating HIV infection, but we have also to take care of other cardiovascular risks. And so the question is now what we could do. And so we decided to do a proviral resistance testing because the initial resistance testing was not available. So we didn't know what the patient had in winter 2019. And so we decided to do a new resistance testing in the idea of changing the ART. And now the question would be, what would you propose? And so question A, to switch to doravirine, or question B, to switch to a regimen with bictegravir, or to keep darunavir, or dolutegravir, or maybe any other option we could discuss.
So the audience is voting now. Give them about 8 more seconds.
Okay, so very nice and very nice responses, I have to say, because this is new data we have, and maybe Dr. Sachs.
Please go ahead.
Dr. Sachs could discuss on that, because it's just his publication, which just came out a few weeks ago, about the use of bictegravir in this setting.
Thank you. And I want to say this was a
a paper that we could put together due to the diligence of the virology group at Gilead, because they actually accumulated all of these cases who were in switch studies who had either a historical M184V or had M184V from archived genotypes, and found that essentially everybody who was switched to bictegravir FTC TAF maintained viral suppression. So even though the FTC in the regimen is, quote, resistant, there's still way excess antiviral activity in the bictegravir and the hyperactive tenofovir that it maintains viral suppression. So there's no issues with this.
Yeah, thank you very much. I think this is really important data for all clinicians because we have a lot of time this situation and we didn't know, we are not really sure what we can do. And here we have a nice and important option, an easy option, I have to say, for this kind of patients. I don't know, maybe one of the panelists has also a comment on the strategy, or maybe something to do differently, also a different way.
Well, I'll comment and say that I think the one thing that you probably wouldn't do is switch to a dolutegravir 3TC dual therapy because of the M184V, that you're kind of leaving the dolutegravir to do all the lifting by itself. And Dr. Sachs just mentioned the relative hypersusceptibility to tenofovir when M184V is present. I guess I got a question back. I mean, you're right. These data were generated from bictegravir. Do you think the same thing would hold true for other regimens with a potent anchor drug like bictegravir, dolutegravir, et cetera, with FTC and, or let's just call it, or FTC and TX V or TXV?
Yeah. I mean, I think that I strongly suspect they would. The one question that comes up is whether an NNRTI would hold it together. And we actually don't have any data on doravirine. Certainly dolutegravir and bictegravir would be fine. What I wouldn't use in this case is doravirine without further data. And that's based on the fact that etravirine was studied in treatment experienced patients who had NRTI resistance, and it didn't work out so well. And I don't know, Davey, maybe you want to comment further, because you certainly are the resistance guru in this group.
Yeah, no, I just think it goes back to what you were talking about with the excess antiviral activity and how many drugs that you have there, and then what the resistance pattern is. And I completely agree with Mike that if there's a M184V and using a 2-drug regimen, that one drug doesn't work, you just gotta think that not going to work.
Some additional data that really supports the fact that you need a high barrier resistance drug. I'm glad you put it that way, Mike, is the old Switchmark study. If people think back a few years, that was a switch onto raltegravir, another integrase inhibitor, but one that has it's easier for the virus to get resistant to it. And in that setting, when there was a lot of nucleoside resistance, it wasn't just M184V though, then raltegravir didn't do as well. So I think we would get exactly the same results with dolutegravir, I would predict. And it's nice to see these data. It's very helpful in terms of clinical practice. Sorry, Dr. Guntard, over to you.
Yeah, no, it's fine.
I just wanted to say, we did a study some years ago in the Swiss Record study together with a French study looking at the switch of dolutegravir, abacavir in 184V harboring patients. So it was kind of a cohort study, but even there, we didn't see a failure signal. So even there it worked.
Okay, so thank you very much for, or Mike, I'm sorry.
Yeah, so a couple of questions came in from the audience. One is, would it help for the cardiovascular risk to switch from darunavir to bictegravir? Does the panel have a strong feeling about that overall?
I have a feeling that the protease inhibitor class as a whole, minus atazanavir, has been consistently associated with excess cardiovascular risk, whereas this one study that was cited earlier, the RESPOND cohort, has a transient effect that it can't be excluded that there's channeling bias. So I would say that in clinical practice, I've done this numerous times. So darunavir switched to bictegravir or dolutegravir for cardiovascular risk.
Yeah. Great.
Okay, so maybe we will just continue then with the next case. Thank you very much. Whoops. And the next case would be the question, should I switch to long-acting cabotegravir in rilpivirine? And this is a second case, a 59-year-old woman from Kenya living for a long time in Germany. And she was diagnosed in May 2002 with an HIV infection. At this time, she already had an hypertension and also high level of cholesterol. And she has a very long ART history. You see it here. We still have some patients, so some interesting combinations and also a ART break for 5 years almost. And since 2016, she is on a treatment with rilpivirine. She has really good tolerability, very good HIV parameters, so everything is fine. Viral load is below the limit of detection and CD4 T cell around 400. Because of her cardiovascular risks, she has some concomitant medication. And then in spring, she was complaining about stigma and also about all the medications she had to take, and always coming every month, always discussing, and her husband just died also. So she wanted a change. And now the question would be, what would you do with such a patient? What would you consider? So question A would be talk to her and keep her on her current treatment. Maybe we could think about also change the treatment and do also a pro-viral resistance testing. Switch her to cabotegravir and rilpivirine, or to do anything else. So we're waiting some seconds. Okay, so many of you just choose also response C, cabotegravir and rilpivirine, of course, because the question was also if we could switch to this treatment. So I think there's of course, there are some different options here we could discuss. Maybe we could just keep on the treatment and talk to her, or do anything else. Maybe, I don't know. What do you think also in the panelists? What would you do? What could we do also? What could we propose her?
We've just been joined by Dr. Hoy, who it's now tomorrow morning in Australia. Maybe we can her a bit of a wake-up call and let her take first shot at this. What do you think, Jenny?
I think we do need to talk to her. If one of the incentives for switching to long-acting treatment is the removal of daily therapy, she still needs to take her antihypertensives and her lipid-lowering therapy daily. So, but if we do remove one pill from her regimen, her daily regimen, I also think we probably do need to understand her resistance, because she did have that 5-year break. We only have what her viral load is now. So we don't know whether she developed any resistance when she stopped her treatment, or had any virological failure, which I think is important to know before starting long-acting cabotegravir and rilpivirine. But if there is no history of virological failure or resistance, then, cabotegravir rilpivirine would be a good option for her to consider.
Mhm.
Just it's a interesting, I think this, if you go back to the treatment history for a moment, if you could, Clara. So this patient would not qualify for the Atlas or FLAIR studies, would not qualify. And yet I'm going to go out on a limb and say, I'm very comfortable switching a patient like this to CAB rilpivirine without doing proviral DNA resistance testing. And that's because she's maintained virologic suppression on a rilpivirine-based regimen for years.
Mhm.
And she is in many ways an ideal candidate for response to rilpivirine-based regimen, since the leading risk factor for failure on CAB rilpivirine is rilpivirine resistance. And I highly doubt that she has it. So I fully get wanting to find out as much as possible in her, because knowledge is power. But on the other hand, I doubt she has rilpivirine resistance based on this history.
Thank you very much, Dr. Sachs. Any other opinion on that also?
Well, generally, the proviral resistance panels are okay, but I think they can be misleading because they could determine maybe the presence of a mutation in a defunct virus that isn't replication competent. So I think it's helpful when we've had failure, like Dr. Sachs was just saying, and I agree with Dr. Hoy that ideally you'd like to know, but I don't know that we're going to gain a lot of new information. I too, I think, be comfortable moving with the injectable at this point, because she's been on successfully treated regimen, really doesn't have any evidence of failure in her history.
So Dr. Sag, do you think her first regimen had some merit? Ha ha ha.
Yes, indeed.
Yeah. That was the name of the study that Dr. Sag actually led. I think that she was probably on that study, the merit study.
And all the patients hated me because they were on AZT.
Yeah, that's true. Okay. Well, but so what we did, we just switched her without any resistance testing because, because of her history. And we could just, as Dr. Sachs just mentioned, we said, okay, if she was just controlled with rilpivirine since a long time, then we didn't think she will have any problem. And so this is what we did, and everything is fine, and she's very happy, and so everything is good. And I just wanted to give some background information about the cabotegravir and rilpivirine. So it is approved only in combinations in patients with HIV who are currently virologically suppressed on a stable ART. They shouldn't have any current or historically documented resistance. This is also what we just discussed here in this case. And we shouldn't have a virological failure on any of these classes. Very important, there are some contraindications, especially the HPV infection. So if there is an active HPV infection, the treatment shouldn't just be cabotegravir and rilpivirine, but we should also have an active HPV regimen. We discussed also the problem if a woman is pregnant or wants to become pregnant, we don't have data on that. But of course, if a person is already on this treatment, you can decide just to continue and to do a lot of controls. And of course, the contraindications if there are any interactions with cabotegravir or rilpivirine. I think what's important, and maybe this is also an issue, it's the dosing, and everybody should know about some issues you could have. So we have, what we do in Germany, we have an oral lead-in for 4 weeks where we just see if the patient is tolerating the medication and if the results are still fine, if we're happy with that. And then we start with the intramuscular phase for 4 weeks, and we repeat it then after this every 8 weeks. If there is, if a person wants to stop the treatment, or if there's any interruption of the treatment, then you should continue as soon as possible, but within the 4 weeks after the last injection with an oral treatment. And here you see the tablets and the injections. And this was an important study here, where patients were switched on cabotegravir and raltegravir, or they just continued ART. And you see that most of the patients had virological success, and this was the basis for the approval of the intramuscular and long-acting treatment here. And I think it's for the HIV treatment it's really something very important. And of course, the 8 weeks issue is not really that what we wish to have, but I think in the future we will have more interesting options also with longer periods of re-injections. Now, I would like to finish with the last case. So how do I manage virological failure? And we have now a man, 46 years old, and he was diagnosed with HIV in 2018. CD4 T cell counts were around 2,050 and 450,000 HIV copies, wild type. And he was started with an efavirenz-based regimen. And I have to say, it wasn't here at our hospital. It was in a clinical practice, and this is why they were choosing this regimen. But he was tolerating it very well. The HIV parameters were also fine. And in spring 2019, the last viral load was below 40 copies and CD4 450. Because of the corona pandemic, he didn't come to the clinic anymore, and so he stopped the treatment, or he interrupted the treatment. And so in fall 2021, he had a viral load of 12,000 and a decrease of the CD4 T cell counts. And of course, in this situation, we decided to do a genotypic resistance testing. And you see here the main mutations we could observe. So the M184V and the K100N mutations. And now the question would be what you could do and what would be ideal for this patient. And we have different questions and different answers. So dolutegravir-based treatment would be answer A and B, or darunavir, or bictegravir, or any other option. So just give us your answer. Okay, so answer was D with bictegravir. Interesting answer, I have to say. Of course, it's an option. There are also other possibilities. Maybe Dr. Sachs, you want to comment this?
Sure. Well, there's we have resistance to non-nukes, and then that 184V, like we've already talked about. And so to me, answers D and answer A are probably the preferred answers here. I would not use abacavir because we've talked about that already, but with a 184V, that does take a hit a little bit on abacavir. So it's not a whole lot different, certainly better than 3-TC dolutegravir alone, but it's just not something we go to. Is darunavir okay? Sure, but I think I tend to get away from a boosting agent if I can as the guy's getting older. So those, I'd say either A or D. See what other people think.
Clara, once again, it's helpful to have the case up just so you can go back and see all the characteristics and people can.
Here?
Yeah,
Okay. Yeah.
very
yeah,
good.
You're right. Yeah. Mm-hmm.
Thank you. So, you know, I think that the Nadia trial was really transformative in our understanding of management of people with resistance in this pattern, because Nadia had people failing first-line regimens with non-nuke plus 2 nucleosides, and then randomizing them to either keep the tenofovir or switch it to AZT, or to dolutegravir, or go on darunavir. And what the Nadia trial showed us was that, you know, basically all of the options were roughly the same, although the ultimately at 96 weeks of follow-up, the tenofovir option, keeping the tenofovir, even though it hurts us ID doctors to do that, to keep a drug that's in a failing regimen, keeping the tenofovir was the better choice, most likely because of tolerability. And the dolutegravir strategy was non-inferior to darunavir, but there was a 9 out of 235 person risk of getting dolutegravir resistance. So, you know, I think that if the patient's very adherent to therapy, it's probably fine. But speaking with Neil Patton about this, the patients who failed with the dolutegravir resistance typically were non-adherent. And so the safest thing is to use darunavir in this context. But I don't have a right answer for everybody.
Although, Paul, maybe I'll jump in here and ask you, this patient going back just had M184V, did not.
Right.
So in Nadia, just to stress the point that was being made,
Yeah.
this was a study done, as was said, in sub-Saharan Africa, and people were very advanced. You see the characteristics there.
Yep.
50% had a CD4 count less than 200. A lot of K65R, which knocks out tenofovir, but also other nucleosides, and a lot of M184V. And so if you take us back for a minute, Clara, to the case, I think you said that this person has M184V alone. And
No.
No,
So
no,
here also the
K103N.
His
K103N.
K103, yes, but the
But
only
nucleosides.
side resistance he has is one M184V, and so I think that this person is a little bit closer to that first case. The NNRTI resistance is there. If you had a lot of worry that you don't have a full picture, but I think if you were just M184V and the nucleosides, then that would. You know,
So I'm just going to say there's a difference, and we should really try to understand this. There's a difference between a stable switch and a virologic failure case. And that's what really Nadia is telling us. Nadia is telling us that virologic failure cases includes people who may not always be so adherent to their regimen. And as a result, they may be at increased risk of dolutegravir resistance. The stable switch patients, on the other hand, they can maintain viral suppression even with M184V plus K65R plus a whole host of thymidine-associated mutations. It's a different situation, and maybe, you know, if a virologist is still on the panel, if Davey's still on, you can say, you know, don't you think it's a harder ask of the drugs to achieve virologic suppression than to maintain it?
Yeah, it's just a harder hill to climb, right? You have to suppress something versus from the beginning versus just keeping it suppressed.
Right.
Yeah.
Well, so I would just interpret Nadia a little differently and to say that those 9 patients came out of that 10% that didn't have success, right? So it could be because, like you said, that they were inadherent, but in practice, we're going to sort of be following these patients pretty closely, right? And he had some success for a while, but you know, if we're following and then we see that the viral load is coming up, then we would confirm that and then check a genotype and then switch. So he may end up on darunavir boosted anyway. So you know, it's hard to tell from a randomized trial because it isn't. They are checking, And I just don't remember what the switch criteria were for failure, but I suspect it was standard. It's just to me, looking at how easy or hard it is
No.
for people to take medicines.
I've
The last
definitely,
one.
I would totally agree with Raj that I'd feel more comfortable in the failure setting
Yeah.
with just a 184V than K65R,
No.
you know, with both. But, you know, in our reviews that we got about these guidelines, they wanted us to explicitly address this issue of K65R plus 184V. And in the context of virologic failure with both of those mutations, from a resistance standpoint, I think we have to assume from Nadia that the darunavir strategy is safer. For 184V alone, who knows? You know, but it is a harder ask than just virologic suppression cases.
Yeah, and that's very.
And I think the nuances of the reason that he had virologic failure are really important, because it seemed that he was adherent to therapy, one might assume, as viral load was suppressed, and then COVID happened. And, you know, did he just lose access to drug entirely? And if he goes back on his drug, he's going to be adherent again. He's going to be able to take his medication. So, you know, if you're leaning toward the dolutegravir regimen, I think you would really want to have that discussion with him about how well he can take his drugs on a daily basis, and otherwise default to darunavir.
That's a good point.
So good
Okay.
point. Yep. So we have just a few minutes left here. We have a few questions. A lot of them are around cabotegravir, rilpivirine. If someone's having low-level viremia, I guess it's a question of how low level we're really talking about here. So if it's over 100, I think we get nervous that it's really beginning a virologic failure. But what if it's 55? Do you accelerate you go from 8 weeks back to 4 weeks to give a little more? What do you guys think?
Well, it depends on what kind of treatment he is, because, for example, we have observed several times patients on treatment on darunavir. They have sometimes something between 50 and 100
That's
copies, and we tested everything, resistance, and we didn't see anything.
Right.
And so I honestly, I wouldn't really care if it's still between 50 and 100. It happens sometimes, and if everything else is fine, I wouldn't do anything. Well, I don't know how the other would decide, but this is my experience.
Yeah, and the reason for that usually is in somebody who had a very high baseline viral load before treatment, and they have a larger reservoir of proviral DNA containing cells, and they're going to spit out virus and we see that all the time with oral regimens, and it would be true for cabotegravir as well. I think because you mentioned the pharmacokinetic tail, and it's been brought up a couple of times, does that yeah, I think what it would say is that we should follow their viral load carefully and make sure it's not going screaming past 100 into 200.
I guess my view is that because unique among our recommended regimens right now, rilpivirine, even with perfect adherence, can rarely have virologic failure with resistance. So as a result, in settings where you're kind of uncertain, it's like one of the questions about someone with a history of raltegravir failure, I would steer clear of it.
Yeah.
And that might also apply to people who have low-level viremia. So for example, as you said, Mike, if it's 28, that would be okay, because we know that the risk of resistance actually increases very quickly once that low-level viremia goes over 100 or 200. But if it's anything really higher than 50, I would probably not use it.
One question that came in, I know we're just about out of time, but I want to turn this question to Dr. Smith because it's asking about the utility, if any, for the use of proviral genotypes in the setting of virologic success, less than 20 copies. Do you see a role for that, and in what setting, or is it just too confounding to be helpful?
It's hard, but I really think that getting a history ahead of time is really good about ART failure that's happened in the past and ART use. But proviral testing can be helpful, but just realize that it's hard to rule out a negative. So if you find a mutation, that's important. But if you don't find a mutation, really go to that history and figure that out.
Okay, so thank you very much, Dr. Lehmann, and thanks to the panel. Wonderful discussion. We'll try to answer as many of the residual questions as we can just by typing in the answers here from the panelists. But now we'll turn it over to Doctors Eaton and Springer, who will take us through substance use disorder.